Hi everybody, this is again to all you residents out there who are struggling in the fight against COVID. Hopefully this helps you to learn something while you're out there and working so hard for the rest of us. This is the lecture on high yield tips for assessing shoulder radiographs, and what we're going to talk about are things that are commonly missed on shoulder radiographs and common views and their value in assessment. So the first thing I want you to remember is that one view is like no view. When we look at this single radiograph on the right, what you can barely see is a faint fracture line that is running through the proximal humeral shaft. And when you look at the second view that we've taken, an axillary view, you can see that there's a very clear fracture through the surgical neck with extensive angulation. So remember, one view can be fairly misleading. When you have a patient who comes in with a fall on the shoulder, one of the first areas to look carefully is at the acromioclavicular joint. If you find that the acromioclavicular joint looks normal and the patient has tenderness over the acromioclavicular joint, remember to consider taking comparative radiographs of both acromioclavicular joints with a heavy book in both hands. So essentially you could take any of the radiology books that you haven't read and put one in each hand, and you will be able to look at the difference or widening of the acromioclavicular joint space. And this is usually because of a stretch in the acromioclavicular joint capsule, and that's called a grade 1 injury. The second thing that you may see widening of the acromioclavicular joint, and when you see this indicates a grade 2 injury, which is essentially because of complete disruption of the superior and inferior capsule of the acromioclavicular joint. In a grade 3 injury, what you will see is marked widening of the acromioclavicular joint space along with superior migration of the distal clavicle, and this happens because of not only rupture of the acromioclavicular joint capsule but also because of rupture of the coracoclavicular ligament which holds the clavicle against the coracoid process. Sometimes you may see an osseous avulsion of the distal clavicle in these patients who have a grade 3 separation injury. One point to be very careful in children is that oftentimes when you look at the proximal humerus, you will see something that looks like a fracture line, such as in this case in the proximal humeral shaft, and essentially what this is a pseudo fracture. So it is the proximal humeral physis that you are seeing in obliquity that can look like a fracture, so be careful for that. The second set of views that you will take in patients who have trauma is the internal and external rotation views, and of these internal and external rotation views, they are very important for looking at two entities. The first entity that we're going to talk about is the one of posterior dislocation. Now these can be hard to diagnose clinically as well as radiologically, and the classically talked finding about these cases is something called the light bulb sign. So if we look at the proximal humerus, in both of these cases it looks like a light bulb staring at you in the face. The interesting thing is that the position or the appearance of the humeral head does not change when you go from internal to external rotation. So it is not just the presence of a light bulb sign, but it is the persistent presence of a light bulb sign when you are in internal or in external rotation. And when you have this persistent light bulb sign, it is a sign that somebody has dislocated their shoulder posteriorly, because in posterior dislocation you have internal rotation of the humeral head, and posterior dislocation the humeral head gets locked against the posterior aspect of the glenoid, and that's why you have this appearance. Another very common injury that's very easily missed, and probably the most commonly missed injury, is something which is called the non-displaced greater tuberosity fracture, and that you can see very subtly over here. Now it's very important that you look for these fractures in external rotation, because in internal rotation that greater tuberosity is facing you and is overlapped by the rest of the humeral head, and therefore you cannot tell this fracture. So it's very important to look at external rotated views, especially when you're concerned about a greater tuberosity fracture. Another common reason why patients show up with pain in the emergency room suddenly is because of calcific periarthritis or calcific tendinosis, and here internal and external rotation views can be extremely helpful. So say for example this radiograph, when we look at it straight up front, nothing really jumps out at us and it looks relatively normal, and this is an internally rotated view because you can see that the humeral head looks like a light bulb. When we look at the same patient on an externally rotated views, you see a rather obvious calcification along the greater tuberosity, and this is an example of somebody who has and when you look on the internal rotated view, you see that this calcification is actually overlapped by the humeral head, and therefore you don't see it so well. And this is the difference between internal and external rotation in terms of bringing out the area of the greater tuberosity. And this is an example of somebody who has supraspinatus calcific tendinosis. Let's contrast this against this case, where you can see in this situation there is a cloudy calcification along the inferior aspect of the glenohumeral joint in internal rotation, but when you go into external rotation, that calcification moves slightly laterally, and this lateral move with external rotation is something that's pretty typical of somebody who has a calcification in the subscapularis. So anterior calcifications will tend to move medially with internal rotation, and posterior calcifications will tend to move laterally. Okay. Another combination of views that's really important is the Grashey and the AP view. Now the Grashey view is an oblique view to the shoulder joint, but it's actually an oblique view to the patient, but it's actually a straight AP of the shoulder, and that's because of the actual angulation of the glenohumeral joint. So when you angle the beam by 35 degrees or so, you will get something called a Grashey view, and in this Grashey view you will be able to see the clear space of the glenohumeral joint very nicely, as opposed to a straight AP view where you will see overlap between the glenoid and the humeral head. Okay, so this is an important differentiation for all of you to remember when you're looking at these cases. In cases of a posterior dislocation, when the humeral head is dislocated posteriorly and overlaps the glenoid, in these cases when you get a regular Grashey view, you will see overlap, or that clear space of the glenohumeral joint will be lost, and this is a subtle but important clue in terms of identifying glenohumeral dislocations. And this is an image, posterior glenohumeral dislocations, and this is an image from the internet which shows you this really nicely. The next set of views that you will think about is something called the Y view, and you may ask why get the Y view, but it's an important view because it helps you to look, it is an on face view of the shoulder joint. So it helps you to see the Y of the shoulder, which means the scapula, the acromion and the clavicle form the Y, and normally the humeral head will lie centrally within this Y. If you have a patient with a posterior dislocation, you will see the humeral head dislocated posteriorly, and you have a patient with an anterior dislocation, you see it dislocated anteriorly. So this is an important view for you to look at it. It's also a great view for you to look at the base of the acromion, the coracoid and scapular fractures. So remember this view carefully, it is the Y view. The last view we're going to talk about is the axillary view, and this is a view that's shot through the armpit, and the idea of this view is really to look at there are many variations on how you can acquire any of these views. And the idea of this view first is to look at the glenohumeral joint. So you can actually look at the glenohumeral joint space narrowing very nicely in this view. So it's good for that. You can also see if there's anterior or posterior translation of the humeral head. And the next thing you can do is you can look at the anterior and posterior margins of the glenoid. So if you're concerned about a Bankart lesion or a reverse Bankart lesion, it's a really good view to look for that. Now if you look past the glenohumeral joint, what you can also see is the acromioclavicular joint in these patients, and this is a nice example of somebody where not only can you see the acromioclavicular joint, but you can see that there is a small accessory os acromiale which you would be hard pressed to see on any other view. The third important finding that you will see in this radiographs in these axillary views is you can help to identify calcification. So you can see if a structure is more anterior or more posterior. So briefly, what I've done in these last 8.5 minutes or so is we've talked about shoulder radiographs. The two major conditions in which you will see these in the emergency room are for acute trauma or acute non-traumatic pain. In acute trauma, the most common things you're going to consider are the acromioclavicular joint, the greater tuberosity fracture and dislocations. These are the most easily missed. And in acute non-traumatic pain, you will start to consider calcific periarthritis, and this will be another issue. So this is just a summary in terms of what the common views we use and their uses. So for the AC joint, remember a straight AP view, which you may sometimes need weight bearing with if you're concerned about a grade 1 acromioclavicular joint injury. The internal and external rotation views are extremely useful in identifying posterior dislocations, where you'll look for the persistent light bulb sign. Greater tuberosity fractures are identified best on external rotation views, and this is probably the most important finding and most common fracture that you will see. Usually nothing is done to treat them, but it's important to give the patient a cause for their pain and know why they will have pain for a longer period of time. Locating calcifications in calcific periarthritis is very helpful with internal rotation views. Remember, anterior calcifications will move medially with internal rotation, and posterior calcifications vice versa. The Y view is important for looking for dislocations as well as structure, as well as assessing the structures of the Y. And the axillary view can be extremely useful for assessing the glenohumeral joint, the acromioclavicular joint, as well as calcifications. So with that, I will end this talk, and I hope you find this useful to you. But these are some common tips that I find helpful in talking about when addressing the shoulder joint and acute pain. Thank you.